Guys, welcome to Clinical Unfiltered, and I will be your host today. Just me, Dr. Sausha. So give me your hearts, your minds, and your teeth, and let's get unfiltered today about the topic of osseodensification and crestal sinus lifts. So specifically how they apply to crestal sinus lifts. So I'm going to go through a case study at the end, but I do want to focus in on these osseodensification drills. Some of you are probably pretty familiar with them. They're these gold-looking burrs. A lot of you, if you don't use them, you've probably seen them maybe on Instagram, on lectures, but they're these gold-looking burrs. There's different diameters, lengths of them. They came out on the market probably like 2014, 15. Don't get me on the exact date, but that's around the time I picked them up and started using them. And I remember at the time there was like a lot of controversy about them because traditional osteotomy drills, so when you're drilling a hole, for example, for a dental implant, if you're drilling a hole, the flutes of a drill traditionally will cut bone and then it's designed to spit the bone out or get stuck in the flutes. So you pull your drill out of a hole where you're making an osteotomy for an implant, and you look at the drill and there's like bone particles in it, or it's been spitting the bone out to make that hole. That's a traditional drill. Now, when these guys came out with their Osseodensification, the current company at the time was Versa or Densa, or maybe the company's name's Versa and the drills are Densa. Don't quote me on that again, but I remember that roughly it's that name brand that came out around that time. And their concept was instead of cutting the bone and spitting it out, was let's push the bone laterally and apically. So the flutes were designed, especially if you run them in counterclockwise fashion. So instead of running a drill like it normally runs in forward, you run it in reverse. Their drills were designed to essentially push the bone laterally and apically rather than spitting the bone out. And in essence, densifying the neighboring bone. And with that concept, I mean, if you're pushing bone apically, you can also theoretically push the sinus floor up or bring bone and compact it against the Schneiderian membrane and kind of push everything up and do a crestal sinus lift with it. They had the concept though. I mean, they were, especially at the time, they were talking about even densifying like type 4 really soft bone and being able to compact the autogenous bone and make it denser. So that I think that's why they've kind of come up with their pterygoid based implants, because that's a region often you're running through very low density bone. So in that fashion, you can have this drill that is increasing the density of the bone in those regions. But that was the whole concept around the time. The thing that freaked everyone out is, I mean, in general implant dentistry, like the science, the literature, the basic concept was is that if you cracked a bone, you induced a healing process. So a nice clean cut of bone wouldn't leave like residual broken pieces of bone in the osteotomy. You'd have like clean, healthy bone that then your implant would screw into. And that's what you wanted. That's what you and that showed that would almost increase the healing process or speed up the healing process because you have fresh live bone to attach to the implant right away. The osseodensification thought process was, hey, well, this bone that was getting spit out is now being either crushed or particles of it are being pushed into like the marrow space. So you're having dead bone potentially, or bone that's going to need a remodel, like surrounding your osteotomy walls, so that your implant's going in and touching this like potentially crushed or dead pieces of autogenous bone or knocked off pieces of autogenous bone inside the osteotomy, and that's what your implant's touching to heal against. So in theory, at the time, a lot of people were saying, oh, this is going to slow down the healing process. But interesting enough, there were some studies that were able to show that, like, I mean, not measuring per se the healing process, but showing that the bone to implant contact actually really never detrimentally got harmed. And often we were getting like higher insertion torques for these implants. So these implants were locking in tighter, as we thought they would if you densified the osteotomy. They were maintaining that high torque value for an extended period of time. So you weren't really seeing that like traditional drop in integration that happens with primary stability after an implant goes in. That's what we always used to think. We used to think implant goes in with primary stability. After like 2-3 weeks, your primary stability drops, and then you're waiting for like 10 weeks for your secondary stability to come back, which is like actual osseointegration. That was like our traditional thought process. And so when we were densifying the bone, we thought we were going to screw with that in a bad way. But ironically, we were noticing it like potentially improving that curve, and we were like never seeing a real drop. Now, with that said, when that drill hit my hand in 2004, 14, 15, I had some unique failures because the drill did feel different than a traditional osteotomy drill. So those osseodensification drills, you really need good irrigation. You really need to watch your, because I mean, because it's running in reverse, you can potentially overheat the bone or apply too much pressure on the bone. And indeed cause microfractures, cracks, and heating of the bone that makes it delay in the healing process to the point where it could harm the healing of the implant. And I did do that. There were some earlier cases, and again, this was kind of a newer concept and burr at the time, a newer instrument. And I was having these unique failures, and I do think it was a part of the learning curve of understanding these burrs. Also, give me a break. I mean, it was residency, and it was like my first and second year of residency, so I could have had these failures based off any other reason. But when I look back, I do wonder if I was like potentially over pressurizing my osteotomy with those burrs, because it's a different feel. Like there's like a bounce to that drill because it's running in reverse. And if you just like shove it into the hole or your osteotomy and just run it and jam it without giving any kind of like play or bounce or letting it irrigate and cool, yeah, of course you're gonna rub the bone dry and heat it up like a freaking campfire. So yeah, you got to play with that osteodensification drill. I'm gonna pull up an image of these drills. I'm gonna share my screen. So these are those gold drills I was talking about, and just like I was showing you, these drills have a very unique and distinct color and shape to them. And again, like in the top middle, I'm showing an image of the drill being a run in reverse, and you can see how like the bone's got this like whiter, almost looks like cortical bone forming around the drill. It's not really cortical bone forming around it. It's just all that bone debris is being compressed, and that cancellous bone is being squished together to give you a more radio opaque appearance. And I've seen this happen all the time where like if you run your osteotomy, you'll have this like white rim forming around the edges of your osteotomy when you're using these drills, running them in reverse. And what you're looking at here is I'm showing it used in different scenarios. The nice thing is this drill is a universal based system, so it doesn't have its own implant system. So these drills are, and if you go to look up these specific drills, you will see they have a drilling protocol for almost every implant system out there. And so it's designed to be used with every implant system on the market. And so I use it a lot because it's got versatility, because you can run it in forward and then it becomes a normal cutting drill. But I'll tell you, the threading isn't very aggressive. So you tend to cause less damage to the osteotomy. You have a little bit more control when you're using these drills. So I've used it so much, it's actually my preferred osteotomy drill. I'll use it for pretty much every implant case, but especially if I'm doing immediate implants on the upper, and especially when I'm doing crestal sinus lifts, areas where I either want to densify the native bone that's there or push up the sinus membrane. I will tell you, utilizing it to push that sinus membrane is probably one of my favorite ways to use it. What you're looking at, its image on the left, is a lateral wall with graft placed inside of it, and what you're looking on the image on the right is actually an osseodensification drill. That's what they used to be. They actually didn't originally come gold colored. They were originally just normal, like titanium colored burrs, but I think after a couple of years on the market, that's when they added that gold coloration, anodized the drill basically. And I'm able to, especially with my guides, be able to make like small access holes and use these osseodensification drills. And I just want to show you the contrast of how aggressive a lateral wall could be versus utilizing a crestal based approach to lift the sinus. Lateral walls are just so much more freaking involved. I mean, there's more risk for really creating a large perforation in the membrane. Plus, you're accessing, when you access from the lateral and the cheek, you are introducing a lot more swelling and trauma to the area that just makes the whole process more uncomfortable for the patient. Yes, you're able to get more visual access in that process, but there's just so much more risks involved. And if it doesn't go well, you now have a much bigger problem than you started with. You do a lateral wall and essentially access from, create a large flap, create a bigger hole, access and place bone into the sinus from a lateral approach. You're going to have a bigger defect if things fail. You'll have your oral antral communications that can form. You'll have like a hole between the mouth and the sinus. Not a good scenario. So the crestal approach is my go-to. And honestly, like the literature supports that you should at least have like 4 or 5 millimeters of native bone before you do a crestal approach and place an implant. I will tell you, I'll have 2 millimeters of bone, 1.5 millimeters of bone, and I still often attempt crestal before I move to do a lateral wall. So I'm going to show you a little, in this case, just how exactly I do this process. I made a surgical guide, and when I do a surgical guide for a crestal site, like I'm doing a crestal sinus lift, I will purposely design an implant to stop just short of the sinus floor. And I think I've talked about this before when I was talking about guides. And so basically what I'm doing here is my initial pilot drill will make it just shy of perforating the sinus. That way, when I bring in my osseodensification drills, I have like a lip of bone that I can push up against, rather than just shoving my drill straight into the sinus and poking through the membrane. And I will tell you something about crestal sinus lifts. The membranes are different per person based off history of trauma, their sinusitis status. Not every sinus is the same. Now, if you take a cone beam and their sinus is just a big old black void, they probably have a very thin eggshell sinus membrane. And if you touch it just barely, it's got a high chance of perforating. Sometimes they've got thickened membranes from, again, they've bad allergies or whatever. There's so many different reasons they'd have a thickened membrane. Those are harder to perf. They're a little bit more precarious in the sense that they could be infected. But sometimes they're just thicker. Sometimes they're scarred. Scarring isn't necessarily a good thing because it's like less good blood supply in the tissue. But there's so many different reasons that might make it less likely that you're going to tear it. A prior failed site of a lateral wall sometimes leaves like thicker, weird, granulated tissue mess that can be some areas easier to lift and some areas like softer. So you have so many different mixed densities in the sinus. So again, like how you're approaching it, the more minimally invasive in my hands, the better. So again, here I actually have plenty of room. Like in this specific case, I probably have like 5 millimeters to the sinus. From a prior site that we extracted the tooth and grafted, and you can see like not much. Well, probably a decent amount took, but they have that dip around the first molar. That happens a lot, where like the sinus will drop in right after the premolar, and the roots are almost like poking into the sinus. So when you take the tooth out, you get very little regeneration, even if you do a phenomenal socket graft. So a lot of those cases, I will see the patient, and I'll say, hey, there's a high chance that I'm going to need to like bump your sinus up. And normally the analogy I give to my patient that I'm about to do a sinus lift, I say, hey, like look at the room we're in, the operatory. Imagine this whole room is your sinus. We're not filling the whole thing up. We're taking like a small stool right here in the corner and lifting it up about that much. So it does not really impact your ability to breathe, your ability to clear your sinuses. And the whole reason we are doing this lift is so that the implant isn't just poking up straight into the sinus, so that we got something in bone tissue covering the tip of the implant. And I will tell you in general, when we do sinus lifts, and historically, we used to use a lot of like xenograft particulate, very cortical or dense bone in hopes that it tense up the sinus really well. And it was radio opaque. So man, it would pop on a PA. You would take a PA and you'd see like a giant white mound forming in the sinus. That necessarily, the thing is, yes, it looks great on an x-ray. And yes, it could last for a very long time in position. Like it'll stay there. The thing is that white opaqueness is very suggestive that the bone is actually not vital. There's a high chance that bone is still particulate. and lasts forever, but that means it's not integrated to the implant. So the only thing really holding your implant in place is the native bone. So I really don't like pushing a lot of like heavy xenograft particulate into the sinus, just because I know it really doesn't help with osseointegration, and that's what I really care about, especially in the upper posteriors where the bone is soft. If all you got is like 1 millimeter eggshell of bone and you've put 14 millimeters of xenograft particulate, like really dense cortical bone that barely turns over, you've grafted with that and you've left that probably won't turn into native bone for a very long time. And your implant might feel like it locks in there, but man, it's not really integrated to anything. Do let them function hard on that implant, and they'll probably lose integration or develop periimplantitis. So I'm really looking to like grow more native bone. So the idea of like pushing the membrane, using autogenous bone or using the native site bone to get pushed up, I like that. Now, can you leave the tip of an implant in the sinus? Technically, there's studies that show you can leave like up to 3 millimeters poking into the sinus, and we have no issue. And you know why we have no issue? Same reason we have like xenograft particulate in the sinus and we think we did a good job. Like, yes, titanium isn't completely exposed into the sinus, but that xenograft particulate like really isn't doing anything for the implant. So in theory, you could just have nothing also. And it's just that 4 millimeters of the crestal bone that's actually functioning to help the implant. So this case, again, back to the case, I've got the guide to kind of stop us just short of the sinus. And then when I go in, I use a tissue punch often and if I have a guide, it's even easier to use a tissue punch because I know that's I could use a smaller tissue punch. Often I go bigger than the diameter of the implant just so I can get a little better cooling of the bone and a little bit of better visualization, but I don't have to go crazy. So I use a tissue punch, remove that excess of tissue, and start using my osseodensification. First, I use the pilot drill, stop it just short of the science. That's when I introduce the osseodensification drills. And they have different diameters. Normally, I start with a 2 millimeter, and it goes 2, 2.3, 2.5 millimeter diameter, and then goes to 3, 3.3, 3.5, then 4, 4.3, 4.5, 5, and I rarely go beyond 5 millimeters. But I think they've got 5.3, and they've maybe even a 6 millimeter, a 5.5 millimeter diameter drill. But I rarely use those sizes. But as I am using my 2 millimeter, I'm trying to feel, and I'm using it in reverse at roughly around 7, 8, 900 RPMs in reverse, counterclockwise, with tons of saline getting pushed in. And I'm going in there with my drill, and I'm pumping it, and I'm trying to see if I can feel that cortical layer of the sinus floor. And often I will. Often I'll be kind of slowed down by something on the sinus floor. And at that point, if you were to shove really, really hard, there's a good chance you will puncture through the membrane. But these drills, especially the 2 millimeters, if you're running them in reverse, the tip is not very sharp or cutting. So even if you do poke through, there's a chance that you're having a bone chip covering the tip of your drill because you're pushing it apically, the native bone, or there's a chance that because it's not sharp, even if you perforate through the bone entirely and you're touching the membrane with a drill, because it's not as cutting or sharp of a drill, it may not even puncture the membrane at that point. But I'll tell you, worst case scenario, let's say you did make a small little hole. If you now jump to a wider diameter drill and continue to do the same thing and try to actually push it beyond let's say I know I have 5 millimeters to the sinus floor, I'm trying to push my drill to 5 millimeters, maybe even a little to 6. I want to know that I got through. And I'll tell you, once you get through, you feel a pushback from these drills. You feel as if like there's a change as you're going to the sinus floor, you'll feel the resistance, and all of a sudden you'll be in and you feel like you can keep pushing it, but it's not the smooth, continuous push. Like you get pushed back. And that's because you're almost infracturing the bone, the cortical layer there, and it's not like creating a hole like a traditional drill would. It's almost infracturing and almost like a V-shaped break into the sinus. That and you're pushing native bone in there. So you'll have some resistance pushing back on that drill. And there is a feel to it. And oh my God, you have to do it to actually feel it. And you slowly, incrementally go up to a bigger diameter. And I like to go to like 3.3, sometimes 3.5 before I start introducing biomaterials into the hole. And my very first biomaterial I like to introduce. So I'll go increase the diameters. I won't really stick the drill though deep into the sinus. I try to stay just to the amount to the sinus floor, or maybe like a half to 1 millimeter in. I'm not, even though I know there's a chance that autogenous bone is going in there, I'm not trying to advance all the way through and puncture the sinus. You could at that point, yes, if you stick this drill enough in there, you will tear up the sinus and poke a hole. You can do that with this drill. You could do that with your finger. So you don't want to, keep pushing it at that point beyond the length of bone into your sinus. You want to know how much bone you have to get to the sinus. So you want to stay within that realm, maybe plus 1 millimeter at tops. The way these flutes are on these drills, they're not very cutting too. So even if the side edges are touching the sinus membrane, sometimes it won't break it at that point as well. So the first biomaterial I like to put, so let's say I did my 2 millimeter drill, ran in reverse, went to 2.5, and how much I jump it bases off the density of the bone. So if it got some kind of density, I'll go the 2.3, 2.5, 3, 3.5, and then I might skip one in the process. The 0.3 sometimes I'll skip, but if it's kind of dense, sometimes I will go 2.3. I won't skip any at that point. But if it's got some lack of density to it, it's really softer bone, and often it is, I will skip that 0.3. So I'll go 2 to 2.5, 3 to 3.5. And that thing is, when you're skipping one, you're more likely to take more autogenous bone with you apically. If you're going like smaller diameters up, you're more pushing the bone. If you're skipping drills, you're more like taking autogenous particles and pushing them up. And so when I'm placing the biomaterials, my first one is actually platelet-rich fibrin. So I take LPRF, I cut it up. Probably each LPRF membrane gets cut up into like 3 to 4 pieces. So not one big piece. And I place it into the osteotomy hole. And I don't shove it in. I kind of just place it in until it's level with the osteotomy, so it's not poking out too much. And then I take my drill and I turn my water off and I turn my RPMs, still running in reverse, but I turn my RPMs to like 25 to 50 RPMs. So really slow. That's why you don't need irrigation at that point. The thing is, you're not trying to like pump saline around in there or anything. You're just trying to have this drill act like a device that's pushing down in a very gentle pressure, pushing the PRF membrane and pumping it into the osteotomy. Sometimes it'll like get stuck in the drill and try to work its way back out, but just keep pushing it and guiding it into the osteotomy and push it to, again, not deep into the sinus, just to the level of the sinus floor. That way now you have a platelet-rich fibrin barrier in the sinus. I want to show you this case. This is the case. I want to show you this completion of this case before I show you any other biomaterials images. And you can see here this specific surgery was super smooth for the patient. So basically, was able to do this crestal sinus lift through the guide and had very little issues and very little trauma too. You can see I didn't flap. I mean, this could be the day of like scanning for all we know. But I wanted to show you in this lateral image, you can kind of see how the biomaterial is kind of tented into the sinus. But let's say as I continue to put PRF, I almost put like a whole PRF in my crestal sinus lift. If it's a smaller crestal sinus lift, and by smaller I mean I have 4 to 5 millimeters of native bone, and I'm just pushing up another like 3 to 4 millimeters. The PRF almost acts like a barrier in case I perforated. So in case I did poke a small hole, now I have some kind of like barrier there to kind of keep things together and glued together and protect any kind of minor perforations that can happen through a crestal sinus lift. Then after I've placed the PRF, then comes the biomaterials. My choice is actually something called Osseodensification bone. It's basically just a softer bone regenerative material. It's almost like a tofu consistency. Again, not very sharp, so it doesn't like potentially puncture the sinus membrane. So I'll cut that up into several pieces and hydrate it in LPRF rather than solid PRF, and I'll put that into they'll place the ossix bone into the osteotomy. Again, not shoving it in, but placing it almost just level with the top of the osteotomy, and then start advancing, again, 25 to 50 RPMs in reverse to slowly push it. And now, as I push biomaterials, again, normally it's over that 3.5 diameter drill, I'm going to start slowly advancing to 1 to 1.5. And I will do multiple increments of this bone graft. I won't push all of it at once. I won't take a syringe, shove it into the hole, all of it, and then keep increments. This is where it gets a little tedious. But you can see I barely created a flap. I just made a punch, a hole, like a little tissue punch. So the time to get to this point where you're finally adding the material, it hasn't taken long. So most of the procedure, the time process, it goes with these small increments of addition of biomaterial. I also will use particulate, more of a cortical cancellous or cancellous particulate with LPRF mixed in to make sticky bone, and I will add increments of that. I'm talking maybe like 1/10 of a cc, and maybe even less, maybe 1/20th of a cc at a time. Just small increments of bone. That way, as I'm kind of pushing that into the sinus, I'm not over pressurizing the sinus. I'm letting the small increments kind of pull the sinus membrane off the bone. So, I mean, it's that small increment is pushing against the membrane, and just as it's pushing, it's kind of peeling the membrane off the bone. That's how we're lifting the membrane, is that small increment. Because if you just shove everything in there, the sinus membrane will catch in certain areas, maybe on a septum, maybe a scarred area. And that overpressure, just the pressure alone can cause the membrane to split open. Imagine a sausage like getting squished so hard meat will like pop through the one end. It's possible to overpressurize these things. So you want to incrementally add that pressure. So I will do that, and then I'll do a midway check to make sure I've got this like dome of bone going along. And then often I'll take a cone beam at the end just to confirm that most of the bone graft is contained within this bubble. And depending on how my drilling is going, let's say it's a 5 millimeter implant or a 4.8 millimeter diameter implant, and I feel like the osteotomy is really dense, I will then use the 4 millimeter and 4.3 diameter drills to open up the osteotomy more to potentially place the dental implant. And I will tell you, in this case specifically, I got so much torque that I actually did place a custom healing abutment and got such good healing, soft tissue healing. You can see the Atlantis abutment on here. I mean, it was a heck of an easy restoration for the restorative doctor when I sent them back, utilizing this custom Atlantis abutment that had great soft tissue contours. I mean, this is a type of implant that doesn't impact food. It looks more natural. It looks like not an apple on a stick. It doesn't look like a weird short implant crown. It looks like a natural tooth in its native position. I wanted to show you all this just to take you to this case. This is really like the test case that I wanted to show you. So this guy came in, short roots everywhere, resorption from orthodontics, but crazy amounts of resorption. Like on all of his natural upper dentition, you can see how much root resorption he has. I mean, he has literally like, I want to say like 3 to crown to, maybe 4 crown to 1 root ratio. Like it's insane. Like his roots are absent. And basically, if you start flapping, and you can see this guy, some would argue this guy needs a lateral window because the amount of bone to the sinus is like 2 millimeters, maybe 2.5. But if you start flapping, and you would need to create a big flap to be able to get the access to do a lateral wall here, you're going to open up the tissue on really thin roots. And we know we lose bone every time we flap. So God knows if you flap on this guy, you might devitalize his neighboring teeth. So I don't want to touch his tissue on the neighboring teeth as much as I possibly ever need to. So again, this is where having a guide, punching a hole, and doing a minimally invasive approach is going to be very helpful for us. But I'm going to have to do a crestal sinus lift. But this guy had so little bone, and often this happens. If there's so little bone to anchor in an implant, I will stage the process. So I'll do a crestal sinus lift, let them heal for about 4 to 6 months, then come back and place the implant, and then let them heal for another 4 to 4 months, maybe even 6 months. That way, instead of doing a lateral wall, I've done a staged crestal sinus lift. And the beauty of that is, again, the trauma's less. If something happens to the crestal sinus lift, we can always revert back and do a lateral wall. But often I get enough lift from these crestal sinus lifts that then I can go back and place the implant, sometimes with a little bit of additional crestal sinus lift push. But I often can get to at least 6 to 8 millimeters of lift with this approach. So I can take this to an 8 without having to do a lateral wall through a tiny little freaking hole. That's what I would rather have in my mouth. And so that's my main approach. So again, here I'm showing you I'm using the PRF and then ossix bone. The only issue here, again, these biomaterials, they do turn over and don't have high radio opacity. So my sinus lifts rarely look super white when I lift, but I know what I'm looking for. You can tell that there's a dome here. So sometimes I will add particulate, but still allograft particulate to see that I'm lifting the sinus. But often I get enough. There's another variation of this using something called Nova Bone. The nice thing about Nova Bone, again, does initially have radio opacity. It's like a soft putty bone. The thing I don't like about it is I feel like it disappears too quick sometimes and doesn't do a great job of giving me much bone at all. So at least the ossix bone I feel like does a better job because it takes a little bit longer to break down. So it eventually does turn over, but it gives me a little bit of that in-between time, that Goldilocks amount of time for native bone regeneration to occur. But here you can see me again utilizing my drills to get to the sinus floor, then utilizing my platelet-rich fibrin and pushing that in maybe a millimeter or two, then using my ossix bone. And I hear it's a 3.5 millimeter drill, run in reverse at 25 to 50 Newton centimeter, 25 to 50 RPMs, no saline irrigation, adding incremental pieces of ossix bone. Then, if I want really take off, and I will, often in these cases where I'm not doing a lateral wall and I'm just doing this through a crestal, tiny little tissue punch hole, I will then add particulate to give it a little bit more substance. But again, still not xenograft. I still don't want cow bone in there. Cow bone doesn't turn over well. So I want something that will turn over. And I mean, if you're looking at the images at home rather than just listening, trust me, these roots are resorbed like no other. You'd probably say just take them out. But these teeth have zero problems. The neighboring teeth are not mobile, because they're probably ankylosed to a certain extent. They're not symptomatic. There's no issues. He's been functioning with them. And this patient is like 45, 46. And he's been like this for a very long time. Who am I to start ripping out all these teeth if I can actually pull off a surgery like this without having to touch his neighboring teeth? So again, you can kind of see here with the particulate how much of a dome of bone. I mean, this is probably lifted more like 10 millimeters. But because there's no implant in there and a lot of this bone will turn over, we won't get that much bone regeneration. We'll get some of it to resorb from the pressure of the sinus pushing back. And what I'm showing you here now is at the time of implant placement, which was approximately 6 months later. You can see we did regenerate bone. We probably regenerated a total of like 6 to 8 millimeters of bone, which then allowed me to place the implant and I didn't actually add any more bone. I still added platelet-rich fibrin and did like a crestal sinus lift with my osseodensification drills, but I didn't add any more bone here. And so what you're looking at now on the right is the implant healed after 4 months after the sinus. So you're looking at implant placement, which was 6 months after the crestal sinus lift. Then you're looking at the implant in place at the time of uncovery, which is 4 months after that. So a total of 10 months from the time I lifted the sinus. And it looks like he's just got new maxilla. It doesn't look like I ever lifted the sinus. It just looks like that's what his maxilla looked like. That's what you want to do with sinus lifts. You want to regenerate the maxilla. You don't want to like have a dome of dust in the sinus at touching your implant. That's not the goal here. The goal is for osseointegration, bone to implant contact that's vital bone. That's what you can achieve by doing, especially, I'll tell you, you notice these results more on crestal sinus lifts than you do lateral walls. You just notice them more often. And one of the main reasons most people doing lateral walls still do it traditionally with a heavy amount of xenograft particulate. But with my crestal approaches, just because I'm adding less bone and I'm almost like letting the membrane tent up against the implant and letting like natural blood clot formations, natural bone regeneration, we tend to have more of a native bone structure that develops around these implants. So in this scenario, I was able to give this guy an implant without touching the roots or the soft tissues on the neighboring teeth. I uncovered with a tissue punch as well. I placed the implant through a tissue punch. And you can see here just the dramatic difference between what the patient started with, which is like, again, 2 millimeters of bone, then to show up with a 9 millimeter implant completely encased in native bone. So grew it a solid 7 millimeters without ever opening up a flap on this patient, using the osseodensification drills and using them for a sinus lift and using them for implant placement as well. Really neat drill. Definitely has a learning curve. The company that does make the implants, they actually do a lot of CE. So if you're curious about learning how to utilize osseodensification drills, the company itself, Versa Densa, they actually do tons of CE courses on pig jaws. They might even have like patient courses or live surgeries. There's a lot of videos on YouTube, I think, that show the use of the drills. And again, the key is learning the RPMs you want to run it at, knowing how to use it in reverse, not to overpressurize and overheat the bone, to learn how to bounce that drill and control it. And I'm not talking like bouncing around like a freaking kangaroo. I'm talking about like a couple pushes in and out, just so you can give time for that drill to cool with the saline irrigation. The courses will give you a good feel for it, and you can kind of feel that bounce. But you got to know the patient's bone structure too. So some will have denser bone, and some will have softer bone. And you have to learn how to, and what I tell people, you don't make a hole to place an implant. You design an osteotomy. And to design an osteotomy, you got to have tools that can factor in for different bone structures. And the Versatool, the osseodensification drills are a phenomenal tool. They've been a big part of my practice. And anyone who does enough implants often has a burr block of this stuff in their kits that help them with a lot of tough implant scenarios, especially in the world of primary stability being king. It helps a lot. And I will tell you, they've come out throughout the years. They've had their normal size drills, which are decently long, but they've created a shorter drill that's great for the posterior. I have a burr block that's got both, so the short and long drills. And of course, they've come out with their pterygoid drills as well, which are super long, that can help you for placing implants in those soft bones. Again, I'm not paid by them. I'm not sponsored. They're not sponsoring, nothing. They've really impacted my implant game, and I love sharing how I use it. If you have more questions, always feel free to reach out to me. And do future, I do plan on doing courses on utilizing those drills and hands-on courses and live patient courses on utilizing Versa drills. But as of late, go directly to them, Versa Densa, and they often got good resources and courses that you can go to and learn a little bit more about using these drills. Thank you guys for getting Unfiltered. Follow, comment, like, tell your friends, tell everyone, tell your grandmas that you love osseodensification. And maybe they'll get you a burr block for Christmas. It's a great stocking stuffer. I don't know when this episode comes out, but it's getting close to the holidays. Thank you guys so much. Take care. Till next time.